Welcome to On Deck at CHCF. We are on the deck at the California Healthcare Foundation, and we're here with Dr. Rita Redberg. Dr. Redberg, welcome.
Thank you, Stephen. It's great to be here on the deck.
So the topic of variation in medicine seems to be one that produces an enormous amount of research and sometimes controversy. Why are you personally interested in this topic of variation?
Well, I'm interested in the topic of variation because I'm interested in the kind of big picture of why we have an incredibly expensive healthcare system and yet we rank poorly on a lot of health indicators. And when you start looking at why that's true, you have to look at what are we spending those trillions of dollars on. And variation explains a lot of that because we see that there is a lot of variation in healthcare procedures, some more than others, and we don't see the variation in outcomes or the variation in disease severity. So we know just because of where you live or what doctor or hospital you go to, you may be a lot more likely to get certain procedures, but that they're not necessarily more likely to make you better off.
Do you feel that reimbursement is a big driver of why certain physicians do more procedures than others?
We reward particularly procedures very well. But it would also not be right to say reimbursement is the only driver of variation.
What are a few other explanations in your mind?
Well, certainly, culture is some of it, and the way people do things. So I think people tend to do things the way they were trained to do things, the way, where you went to medical school, where you did your residency or your fellowship, the way things were done there tends to be then the way you think things should be done. And while we would like to think that that is all evidence-based and uniform, it's not actually true. And once you've invested, say, in a very expensive CT scan machine or these proton beam machines that are now being used to treat all kinds of different cancers, even though the evidence isn't really there, they're very expensive. So once you have them, people tend to use them, and that drives a lot of...
So the medical industrial complex.
Yes.
You are a cardiologist, and at the All Over the Map series, we have a section on cardiac procedures, and the data seem to show that 3 of the procedures, the number of procedures has fallen over the last 7 or 8 years.
Right. Well, it's very interesting data. I mean, the procedures that have fallen are some of the what we call bread and butter of cardiology. It's cardiac catheterization for stenting and for bypass surgery have fallen pretty dramatically since CHCF has been tracking it since 2005. It's a really important first step is to collect that data and then make it publicly available as CHCF did. You can do it by county, by hospital, and then you can also feed back to individual physicians. How are their numbers comparing to their colleagues in the same hospital and also statewide and even nationwide?
That seems like it would be really difficult to figure out what's the right level of the baseline and then who's way above and who's way below. So do you get that question a lot when people say, well, how do you know that this is too much or this is too little?
Absolutely, and that's an important question, but you can kind of determine whether this is too much or this is too little, and really looking at outcomes is the best way to do that. So where are the outcomes look the best? Because really the whole point of doing any kind of procedure or treatment is so that people either feel better or live longer. So if you combine your data on use of procedures with outcome data and see where are people doing better, then you get a good idea of what is the right number.
And going back to the monetary aspect of medicine, which is kind of unavoidable, do you feel that reimbursement is a big driver of why certain physicians do more procedures than others?
So it's really hard in the United States to separate reimbursement from anything else because we have a fee-for-service system. We are the only Western country to have a fee-for-service system. Kind of most other Western countries have a more government-run or a single-payer system, and what fee-for-service does is reward volume. And so it's really hard to separate and pull out the fee-for-service component from the rest of the system. There isn't anyone who says, oh yes, I did that procedure because I wanted the money. but it's very hard to pull that out of the system without actually changing the system. And I think certainly a big improvement in healthcare would be getting away from fee-for-service and getting towards alternative payment models.
Thank you. It was a really illuminating conversation. I think we all want to feel better, live longer. Thanks so much for being here.
Thank you, Stephen.